It's not good. And now part of it, the vaccination has been supplied, and part of it is because of the Belgian companies didn't honor their contracts.
Yeah.
But Trudeau really dropped the ball on that. Well, his ministers, who set that up, majorly dropped the ball on that. They should have had other contracts. Thing is, one of the biggest vaccine makers in the world, the US, is next door.
Yeah.
Just contact the US. That should have been easy. But okay. The Brazilian variant, P1, there are more cases of P1 in Canada than there are in parts of Brazil. Why on earth didn't they ban flights from Brazil? Guys, this is Public Health 101. They completely dropped the ball. Okay, folks on Zoom, can you hear me?
Yeah, we can hear you.
Cool. Okay. Evan, how do you feel? You're showing symptoms. Are you okay?
Yeah, I feel fine. We're just contact traced, so I have to quarantine.
Okay. Okay. Hopefully you'll continue to feel fine. All right, we're gonna get started. Okay, folks, it's time to get started. We're going to begin. Let's see. If you want to pick up your exam, they're graded. There have been questions. The score on Blackboard is curved. It is curved. So there was a 14-point addition to your score. So that score on Blackboard is curved. And then we have people who have not taken the test yet, so don't flash your test around, please. I'm honor system here. We have, as you guys know, the baseball team is on quarantine, and several of them are joining us on Zoom. Say hi, Evan. Say hi, John. So we need to find a time when they can take the test on Zoom. We're still working that out, so please don't show your test to anybody who hasn't taken it yet. And we're going to skip opioids and go to asthma. If I do circle back and do opioids, that'll be a bonus. John, JP.
I have a question about the interview with the pharmacist.
Yeah.
You are already done it by phone. Do you still need the YouTube video?
Yeah, because I want to know want you to tell me what you learned.
Wait, so is the YouTube video not supposed to be the interview?
No, that's you taking what you learned, assimilating it, and putting it into a presentation that you tape.
Oh, I totally misunderstood that.
Yeah, no. The interview is to inform you.
Oh.
Then you report to me what you learned.
Okay, that makes way more sense.
And we had an incident. In fact, Allison had a pharmacist confuse two drugs that are closely related. He said that gabapentin was a Schedule 4. No, pregabalin is a Schedule 4, gabapentin is a Schedule 5. So, and it's easy to get those mixed up because those two drugs are pretty similar in mode of activity, except pregabalin's a lot more expensive. Gabapentin's cheap. And if you guys want an example, Allison turned hers in. Very, very nice video. Exactly what I wanted. So if you want to watch her video for little tips, you can watch Allison's video. I can give you the link. Just done on her phone, obviously in her residence, and very relaxed setting. She might have been in her slippers for all I know. So very, very well done. And that's essentially what I wanted. Okay. Yeah. Asthma. I was going to say something else. What was it? Yeah, whatever, it must have been a lie. Okay. Now, asthma often gets confused or it gets conflated with allergic rhinitis. Allergic rhinitis. And many of you either have or have had allergic rhinitis. So achoo, 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 your eyes water, they get bloodshot, your nose waters, you're blowing your nose 37 times 10 to the 6 times per day. You need to buy stock in Kleenex, and your nose itches, and you're miserable. You might even wheeze when you breathe, but it's due to seasonal types of allergies, usually pollen. And there's things in Michigan that a lot of people at least have some reaction to. Goldenrod, for example, when the conifer trees dump their pollen, some people have allergies to those. I personally am violently allergic to olive pollen. And I went to UC Davis. Davis is the olive capital of California. So for April, I was one very unhappy customer. And so on and so forth. This is its own thing. But some of the drugs used to treat asthma are also used to treat allergic rhinitis. So these two have overlap, but they're not the same thing. Asthma is an obstructive disease of the respiratory system. It's obstructive. Allergic rhinitis is a disease largely of immunological origin, and it's not obstructive. It is a mighty inconvenience, but it's not an obstructive disease. So let's review a little bit about the respiratory system, if we might. So the respiratory system is broken into two zones. There's a conducting zone and a respiratory zone. The actual gas exchange occurs at the respiratory zone. The conducting zone is plumbing to get the air to the respiratory zone. That might sound a bit dismissive, but that's essentially how it works. So your conductive zone consists of a trachea. The trachea is essentially opened at the larynx. And you can feel it right here, this little Adam's apple thing here. Got your thyroid cartilage there. Your thyroid sits right on that. If you feel that, that's essentially your thyroid there. These are right there. That's your trachea. It's got a little C-shaped cartilage in between that. You have connective tissue that branches into a right and a left primary bronchus. Those then branch into primary bronchi. Primary bronchi. The primary bronchi branch into secondary bronchi. And then the secondary branch into, you guessed it, tertiary bronchi. Tertiary bronchi branch into terminal bronchi. And then those will end in respiratory bronchi. The respiratory bronchi now begins the respiratory zone. So you can see them here. Let's pull out our magic pen. So this is a terminal bronchus here. There's another one there. Oh, come on, you. And then let's get a different color here. This is the respiratory bronchus. Notice the respiratory bronchus sprouts these little grape-like sacs called alveoli. And the alveoli are going to be lined with lots and lots of very delicate blood vessels. That's the site of gas exchange. So if you look at the lungs, you'll notice the lungs are not the same shape, are they? Why do you think they're not the same shape? Any guesses? What fits in between the lungs? Your heart. So notice the left lung has that indentation in it, and that is labeled here the cardiac notch. Cardiac notch. That's to make room for the heart. And then if you look at the bronchial tree itself, oh, another thing. Notice the right lung consists of 3 lobes. Left lung consists of 2 lobes. 3 lobes on the right, 2 lobes on the left. So it goes from 2 to 3. 1, 2, 3. That's a kind of way to remember that. You go from right to left. Yeah. If you look at the bronchial tree itself, you'll notice you get a very early branching here on the right side. See that? That marks the right side. So if you see an epoxy model of a bronchial tree, the early branching tells you that's the right side. So if you take a look at one of these alveoli up close and personally, it looks like this. It is single cell layer thick, very thin, very delicate. And then look at that blood vessel. It's right up against that thing. See how close together those are? That's the reason you get good gas exchange across that surface. Now, if you have inflammation, this can potentially fill up with fluid. That's called acute respiratory distress syndrome, or ARDS. What do you think happens to gas exchange when that fills up with fluid? Think gas exchange is very efficient? No, it tanks. And that's the reason why people with COVID-19, at least if they have advanced COVID-19, and remember, COVID-19 is a disease of stages. First stage is just infection of the upper respiratory tract. The majority of people don't advance to the next stage. The next stage, there's very little viral involvement. The virus is largely cleared from the body, in most people, at least. The inflammation that goes on down here is largely an autoimmune event. That's why steroids work so well to treat the later stages, but you definitely don't want to use steroids in the early stages because that'll prevent you from fighting the virus. This is also why antivirals work so well in the early stages, but they don't work so well in the later stages. So remdesivir, the big study in China showed that it doesn't work. And if you go through the data and you look at when they were giving it to people, they were giving it to people on day 7, 8, and 9. Well, when do people transition from the early to the later stage? About day 6, 7. So they're giving it too late. No wonder it doesn't work. There's no more virus. And so much of what's been published now in this COVID era, when you pour over the data, you have to be really careful with when things are given. You have to really look at details because some of the work, the drug is just given at the wrong time. So that's why some drugs work at certain stages, other drugs work at other stages, and they don't work at one stage or they work at the other. All right, end of that little sermon. So you have these thin cells. These are type 1 alveolar cells. And you have another cell here that looks like a foosball. You guys know what a foosball is? Okay, I see some of this, and I see some of this. It's sautoid, and it's got little fringes on it. And if you shake it, it goes jingle, jingle, jingle. Yeah, yeah. Well, my generation, we called them foosballs. What do you guys call them? I don't know. Okay, then call them foosballs. Then we're all happy. So this thing is called a type 2 alveolar cell. Type 2 alveolar cell. That cell makes surfactant. Surfactant. What's surfactant? Surfactant is a detergent. A detergent. Why do you need to make detergent in your lungs? Here's why. When you breathe in and out, this alveolus will tend to expand and contract, expand and contract, expand and contract. This surface is wet. If it's just water, it's going to contract and collapse. And then trying to uncollapse it is going to take too much pressure, more pressure than you can generate. By making detergent, you prevent the water from being so sticky. So now it will expand, won't stick together, contract, expand, contract, won't stick together, expand, contract, won't stick together, so on and so forth. Then you have the floor manager of the immune response in the lung called the alveolar macrophage. The alveolar macrophage. This is a professional phagocytic cell. And it goes around looking for debris. It clears the lungs of debris. And if it encounters pathogens, it will release cytokines that essentially alert the immune response and will cause an immune response in the lung. Oh, another thing. If the lung scars, you deposit collagen here. Now this is further away from the alveolus. What do you think happens to gas exchange then? It's worse. So if you see scarring in the lungs, good case point is chronic smoking. Now, not only are the alveoli damaged, you get fibrosis of the lung. That's called chronic obstructive pulmonary disease. In that case, you have permanent decreased gas exchange potential. So a cross-section in a slide of a lung, once again, underscores the very delicate, very beautiful design, essentially, of this structure. These alveoli communicate with each other. They have pores. So air doesn't necessarily get trapped in one if there's damage to one or something like that. And then you've got blood vessels, very delicate blood vessels, pockmarking this. And that's essentially how gas exchanges occurs in the lung. The conducting zone is lined with a columnar epithelium. The columnar epithelium is ciliated. And there are goblet cells that make mucus. The mucus acts like flypaper. Any rubbish you inhale adheres to the flypaper, the mucus, and then those cilia act like an escalator. And they move the mucus with the rubbish up to your pharynx, and you swallow it. You get rid of it. So this system is self-clearing. And here's a little slide showing you essentially the structure of this. So you have the bronchial epithelium. Underneath that, you have a layer of smooth muscle. You have a nice, big, beautiful blood vessel there. And then cartilage. You have cartilage throughout the respiratory system supporting it. But when you get to smaller bronchial tubes, you lose the cartilage. Here is an up-close personal shot. So you can see here, I think, I hope. Can you see that? See the cilia here? And then this pup here, that is a goblet cell that makes mucus. And then you also have in the conducting zone glands. These are mucinous glands. They make mucus too. And these will have little pores that will send mucus up here, and this will move the mucus in this direction here because of the cilia and these mucinous glands with the goblet cells and the cilia, they form the so-called mucociliary escalator. Mucociliary escalator. Okay, see this smooth muscle here? There's quite a bit of it. That smooth muscle is going to determine the diameter of the bronchial tubes. Bronchial tubes can constrict or they can relax. They relax in response to sympathetic input to the lungs because those smooth muscle cells contain beta 2 adrenergic receptors. So when they receive norepinephrine, they relax. They're also innervated by cholinergic nerves from the vagus nerve. Those release acetylcholine. Acetylcholine will cause those muscles to contract and cause bronchoconstriction. Bronchoconstriction. So they have both muscarinic and beta 2 adrenergic receptors. So bordering the thoracic and the abdominal pelvic cavity is the diaphragm. And this is kind of parachute-shaped, dome-shaped muscle. And the contraction and relaxation of the diaphragm will change the volume of the lungs. You change the volume, you change the pressure. By changing pressure, air will either enter or leave, depending upon the pressure differential between the lungs and the outside world. When the volume of the lungs increases, that drops the pressure in the lungs. Air comes in. When the volume decreases, pressure increases. And now air leaves your lungs and goes to the outside. So it's very much a result of pressure differences. And the lungs are also surrounded by pleural membranes. There's two of them, visceral and parietal pleural membranes. And there's fluid that those pleural membranes secrete, and that's just called pleural fluid. They act as a lubricant so that those membranes slide over each other. So asthma, as we said, is an obstructive disease. Now, chronic asthma will lead to remodeling of the airways. That remodeling is permanent. So your biggest goal in the treatment of asthma is to, 1, relieve symptoms, 2, prevent remodeling. Prevent remodeling. By relieving symptoms, your patient can now live a normal life, do the things they like to do. By preventing remodeling, their lungs will stay that way. Exercise-induced asthma seems to be, 1, inherited, 2, some people grow out of it, 3, yeah, it's a little friend of yours there. Yeah. Okay. There. Spiders are our friends, but I don't like them inside. Exercise-induced asthma. That seems to be due more to cholinergic input to the lungs. And typically, exercise-induced asthma, my middle daughter, Stacy, who danced, She got exercise-induced asthma. She grew out of it. And that's not all that uncommon. You grow out of it because your bronchial tubes, as you grow, get bigger. So any constriction you get now is inconsequential. Okay, let's look at asthma pathophysiology. So here is a normal airway. Here's one that's been remodeled by chronic untreated asthma. That's a lot of things that's going on there. So look at it. Let's take a look at the differences between the left and the right. So Nana, can you tell me one difference between this tissue and this tissue? Just give me one thing. There are a lot of things that are different. Just give me one. Oh, okay, yeah. There's more space. More space. So this is constricted, chronically constricted. Okay, Greg, can you give me another difference? A material within the basement membrane? Oh, the basement membrane is bigger. Yeah, it is. The basement membrane is bigger, and that leaves less space for air. You're correct. JP, what else? Yeah, yeah. That's actually due to more blood vessels. You get more blood vessels, and then there's actually more goblet cells and more mucinous glands here as well. So that makes the whole thing look a lot thicker than this here. Dan, your turn. Oh, yeah. Smooth muscle. You have more cells, and the cells are bigger. Jacob, give us another one. What's this blue stuff here? No, that's mucus. There's a lot more mucus over here than there is here. This, you have more glands and they're overproducing mucus. That mucus is plugging the airways. That's really commonly seen in chronic asthma. Hermana, you see anything else? Point it out for me. Yeah? Well, actually, see now there's lots of little ones all pockmarked over there. That's a good point. The vasculature has been remodeled. And that because the vasculature, there's more vasculature, there's less room for airway. So, and you get kind of the mule's end here, Sarah. Anything that you can see that wasn't already mentioned? They pretty much hit it all, so you're off the hook. Yeah, so this is severely remodeled. And this is irreversible. This person will wheeze constantly. So your mission, should you accept it, is to prevent this. Let's take a look at how this happens. First thing, asthma is caused by triggers. It's caused by triggers. Those triggers are different for each person. Tendency to have asthma and be triggered by certain things is usually inherited. The genes responsible for that are just now being uncovered. But asthma will run in families. That's why a medical history is going to be so important. Ask about mom, ask about dad, ask about Aunt Sue, ask about Uncle George, ask about grandma, grandpa, siblings, so on and so forth. Medical history, first things first. Now, you will have some sort of reaction to something environmental. Your immune response will respond to it. And a group of cells called T helper cells, but type 2 T helper cells will predominate in the immune response against this entity. So you get some trigger. That trigger different for every person. One person may get asthma to that trigger, another person may not. It's very individual. And that immune response is characterized by increased dominance of type 2 T helper cells. Type 2 T helper cells. So here is my attempt. Again, I'm not an artist, and you can see why, to draw an airway. Oh, Kelsey, come on, it's not that bad. You're sitting there ready to, you're holding your sides laughing, but it's just, for me, this is pretty good. So you should be applauding. So you have a pseudostratified epithelium, goblet cells that makes mucus, basal membrane, blood vessels, fibroblast smooth muscles, then nerves, sensory nerves and cholinergic nerves, innervating the smooth muscle. You have an insult of some sort. Your body responds to it with an antigen presenting cell. Antigen presenting cells are throughout your body. They sit there in your tissue looking for foreign substances. Once many of you got your vaccine, that's what picked up those foreign substances made by the RNA, were these antigen presenting cells. They picked them up, they took them to a regional lymph node, and there they presented these foreign substances to immune cells in that local lymph node. That's why some of you, when you got your injection, you had swelling of your lymph nodes in your armpit. Any of you get that? No? Oh, I'm seeing a few people nodding their heads. That's your local lymph node, essentially, for injections here. In that lymph node, they present the antigen to T cells and B cells. The B cells make antibodies. The T cells will make molecules that modulate the immune response. And T cells will also, in some cases, recognize virally infected cells and things like that. So these cells are now sensitized to the foreign substance, sensitized to it. So if you get exposed to it again, here's what happens. Your T helper cell recognizes this foreign substance. It now makes 3 molecules. 1, interleukin 4. Interleukin 4. Second substance, interleukin 5. Interleukin 5. Third substance, interleukin 13. Interleukins 4, 5, and 13. What do these do? Interleukin 4 signals to B cells. The B cell normally makes antibodies. It makes different types of antibodies, but it tells the B cell to switch its antibody production from IgM to IgE. IgE. IgE are antibodies involved in allergies. Now, the antibodies involved in allergies. Interleukin 5 is a pro-survival molecule for a group of white blood cells called eosinophils. Eosinophils normally are found in large numbers if you have a worm infection. But they also play a role in asthma. So they are going to make proteins that are going to damage the epithelium here. And the myelin basic protein is one of them. Make several others too. These eosinophils, they survive, they're activated, they now start secreting their nasty things They're going to damage the epithelium. The other thing they make in interleukin 13 has a direct effect on smooth muscle. This is going to cause increased cell division of smooth muscle, and it will cause enlargement of smooth muscle. You get smooth muscle hyperplasia, more cells, and bigger cells as well. Hypertrophy. Escaped me for a second. Now, a word about IgE. In cases of allergic rhinitis, IgE will, after being secreted, will attach to these tissue-based cells called mast cells. Mast cells. Mast cells are all over your body. They're just embedded in tissue. Now, usually, when an antibody binds to a foreign substance, that marks that foreign substance for destruction by a white blood cell. So cells bind antibodies, usually, that are bound to foreign substances. And by the way, we call foreign substances recognized by the immune system, we call them antigens. Antigens. IgE antibodies can bind to mast cells without being bound to antigens. So essentially, the mast cell gets coated by these IgEs, and now the mast cell is kind of locked and loaded and ready to go. If now you're exposed to the substance that triggers your asthma or triggers your allergies, those substances bind to the IgEs on the mast cells. When the IgEs on the mast cells are cross-linked, the mast cell spills its granules. It spills its granules. And those granules are loaded with histamine. Histamine. Histamine causes two things to happen. Well, more than two things, but two things mainly to happen. So if this is a blood vessel here, these cells here on the outside, these are your endothelial cells. Oh, that's pathetic. So if a mast cell releases histamine, histamine causes these endothelial cells to contract, they shrink. So these are going to shrink. When they shrink, the capillary now becomes leaky. So you get leaky capillaries. No, the vessels don't shrink at all. The vessels stay the same diameter, but they leak, which means the surrounding area is going to experience edema. Second thing that happens with histamine in the respiratory system, your smooth muscle in response to histamine is going to constrict. So you get exposed to goldenrod pollen. Your eyes start to water. Your eyes also start to look really bloodshot. Your eyes really start to itch. That's histamine. Histamine is causing those vessels to leak. The other thing histamine does is it activates pain receptors. And pain receptors, when they get bound by histamine at low concentrations, they cause itch. At higher concentrations, they cause a burning sensation. That's why your eyes itch. That's also too, sometimes you'll get a tickle in your throat. It feels like an itch. That's histamine. So that's why you take what are they called? Histamines. Histamine binds to the histamine H1 receptor. And antihistamines are H1 receptor antagonists. And that's how they work. So, going back to our slides here. So you release histamine, and you also, now histamine tends to work quickly and pretty fulminantly, but histamine has a short half-life. The other thing released by the mast cell is a molecule that takes much longer to work, but is a lot more powerful. And that's called a leukotriene. A leukotriene, which you see listed here. Leukotrienes are powerful constrictors of smooth muscle. The other thing leukotrienes do is they summon white blood cells to the area. So IgE is going to sensitize mast cells, is going to cause the initial symptoms of asthma: wheezing, shortness of breath, watering of the eyes, coughing. You can't catch your breath. That is usually the result of histamine. So here essentially is IgE compared to other types of antibodies. You have these 5 different groups of subtypes of antibodies. The first one made by cells is IgM. They make it with IgD. IgD is never secreted. IgM is. And then after the B cell makes IgM, in response to cytokines made by T helper cells, it undergoes so-called isotype switching, and then it makes either IgA, which is a secretory antibody, IgE, which plays a role in allergies and also plays a role in worm infections, and then IgG, that's the major secondary antibody that's made. And so if you get a antibody test, say for COVID-19, you've been vaccinated, IgG antibodies say you have memory, you have immunologic memory, because those are the antibodies that you make when you have a secondary response. These are high affinity antibodies. IgM antibodies are not that high affinity. And so the mast cell, in response to the cross-linking of IgE, dumps its granules full of histamine, leukotrienes. There's a picture, EM picture, showing you a mast cell after its degranulation. You see these granules here. Those granules are getting dumped with all this material now out here. And that's what that looks like. Here's an eosinophil full of granules as well. And those granules contain proteins that are meant to kill worms. They can also kill the epithelium of your respiratory tract. Okay. So when this happens, you damage the epithelium. That's called epithelial shedding. Nerves are exposed and irritated. That induces coughing. And then you get bronchoconstriction. That causes wheezing and difficulty catching your breath. That's called dyspnea. Dyspnea. D-Y-S-P-N-E-A. Dyspnea, just shortness of breath, trouble breathing, which is a hallmark of asthma. It's a hallmark of other diseases too, but particularly of asthma. So that's stage one. So stage two, first stage of modification, basement membrane thickens. That's the response to these fibroblasts. They are responding to the growth factors made by the T helper 2 cells, and also to the damage and the chemokines made by these cells as well. They make chemokines that activate the fibroblasts. One of them is fibroblast growth factor. The other is platelet-derived growth factor. These fibroblasts now will make more of this basement membrane. That is going to narrow the diameter of the airway ever so slightly. Stage three, now you have hypertrophy and hyperplasia of bronchial smooth muscle. This will further decrease the diameter of the airways. That's in response to interleukin 13. Interleukin 13. Stage four, immune cells also make a protein called vascular endothelial growth factor. Vascular endothelial growth factor, which is mercifully abbreviated VEGF. VEGF causes proliferation and widening of the vasculature. That's going to further decrease the diameter of the airways. Stage five, now you get hyperplasia and hyperactivation of goblet cells and mucinous glands. So now you thicken the smooth muscles, you've thickened the basement membrane, you've increased the number of blood vessels, and you filled it with mucus. So now you take the airways and you narrow them, and then you fill them with mucus. Also, one other feature, this modified smooth muscle responds to norepinephrine very poorly. So not only is it thickened, it doesn't relax normally. This is permanently remodeled airways. So this looks like this airway over here, this one here. And that's essentially how you got there. Once you get to stage 4, it's reversible. Once you get to stage 5, it's not reversible. So treatment will help you prevent remodeling. That's why treatment is so crucial. That's why untreated asthma or undertreated asthma is potentially dangerous to the patient. All right, so the early, yeah. Oh, Allison, it varies. It varies. Childhood asthma is common in a certain population. Childhood asthma can be treated. There are lots of good treatments for kids with severe asthma. Some get asthma later in life. Some have very, very, very mild asthma. It only gets worse later in life. It's different from person to person. So you can't really say at a particular age somebody gets asthma. Also, do they smoke? That can be a factor too. But some people who never smoked a day in their life have asthma. Now, I will say this, asthma is more common in kids whose parents smoke. A lot of other things are more common in kids whose parents smoke, like sudden infant death syndrome and things like that. But it varies because asthma is a marriage of genetic factors and environmental factors. You have to have both in order to get asthma. That's very clear. Right, so there's a early response, late response essentially to these allergens. The early response is mediated by histamine. Late response is mediated by leukotrienes. If you use an antihistamine, for some people, that's all you need. For others, that won't be the case. We talked about innervation. This is just to reinforce it. So it's innervated by the vagus nerve and also by sympathetic nerves as well. Vagal nerve stimulation causes bronchoconstriction. So there are some ways to mediate this bronchoconstriction caused by the vagus nerve. Let's go through this here. So this input is acetylcholine, and that binds to a receptor, a muscarinic receptor, the so-called M2 receptor, the M2 receptor. You can block that receptor with a muscarinic antagonist. And there are several inhalable muscarinic antagonists that you can use. Now, you can also use drugs that mimic sympathetic input. So you can use beta-2 agonists. And there are several inhalable beta-2 agonists you can use. These will promote bronchodilation. They'll promote relaxation of the smooth muscle. When they bind those receptors, they promote cyclic AMP production inside the cell. That promotes relaxation of the smooth muscle. You can also use a drug that prevents degradation of that cyclic AMP. That drug is theophylline. Theophylline. Theophylline comes as an oral and an injectable version. Theophylline also binds to adenosine receptors. And it prevents adenosine from binding to its receptor and causing bronchoconstriction. So theophylline does kind of a twofer. So these things here, muscarinic antagonist, beta-2 agonist, and theophylline, they promote relaxation of the bronchial tubes. Mind you, asthma is a disease very much caused by inflammation in the bronchial tubes. These drugs do not affect inflammation, but they do cause relaxation and dilation. All right, let's get to medications. First thing let's look at are prophylactic medications. What does that mean, prophylaxis? Prevention, that's exactly what it means. A prophylactic measure is a preventative measure. So the first prophylactic treatment targets immunoglobulin E. And that is a monoclonal antibody that binds immunoglobulin E and prevents it from binding to mast cells. This antibody is called omalizumab. Omalizumab, it goes by the trade name of Xolair. Xolair. Omalizumab has been extensively researched. It's very safe. It's also safe for use in children. And it comes, as you can see, in an injector like this. You still have to go to the doctor's office to get it injected. A self-injector, injector pen, is up for approval by the FDA, but like a mighty turtle goes the FDA. So it'll probably be approved just before your grandkids are born. And then, no, I'm kidding. Well, actually not. That means people with allergies who use this drug will be able to inject it at home. They won't have to go to the doctor's office. So this drug prevents the binding of IgE to white cells. It also decreases circulating IgE. For some reason, that decreases the amount of eosinophils. You decrease the amount of eosinophils, you decrease mediator release. So this drug is very, very good for people whose asthma is linked to allergies. Not everyone's asthma is allergy linked, but those whose asthma is allergy linked tend to be very heavily benefited by omalizumab. This drug, unfortunately, is terribly expensive. So insurance companies won't fund it unless you failed with other treatments. This drug is about $1,000 a shot. You get a shot once a month. Yeah, it's not cheap. Monoclonal antibodies are very expensive to develop and very expensive to produce and then package. So the company will charge what they can, but they need to recoup their costs. They've got costs like everybody else. And this drug's license will run out next year. I think next year. That should bring the price down. Also, there's some bioidentical forms that are going to come out probably pretty soon. That'll compete, cause competition. That'll drive the price down really fast. Competition, competition, competition. These drugs here These are drugs that stabilize mast cells. So they prevent the mast cells from blowing their top. These are inhaled. So there's chromolant sodium and chromal sodium. You have to take these prophylactically. These will not work to quell an active asthma event. They're only used preventatively. Interleukin-5 plays a really central role in recruiting eosinophils. If you have an asthma that is characterized by very high eosinophil numbers, your treatment is going to tend to be more difficult. You will have so-called refractory asthma. By decreasing interleukin-5 activity, you can treat their asthma very effectively. And there are 3 monoclonal antibodies that attack interleukin-5. There's 2 that bind to interleukin-5 itself, reslizumab and mepolizumab. And then there's one that binds the interleukin-5 receptor and blocks it, called benralizumab. These drugs are very effective in eosinophil-specific asthma. Mepolizumab and benralizumab come as injector pens, and the patient can self-inject themselves. Remember the rules for SC injection: 2 inches from the navel, 1 inch away from a scar, and don't rub it after you inject it. And then rotate your sites, and don't inject into the muscle. Reslizumab is intravenous. You have to go to the doctor to get that one, which makes it not very convenient. These drugs are new. They're very well tolerated, and they're very expensive because they're so new. I've got some prices down here. I'll read them to you on Friday. Okay, that's all we have time for. I will see you guys on Wednesday.
Hey, I have just a few questions that I wanted to ask you about.
Yeah.
So the first one is the final going to be like a simulated exam? Is this going to be over the rest of the show that we have?
Just and the cholesterol stuff that I forgot to ask you about.
Yeah. Okay, and then the next question is, we're supposed to record ourselves on a YouTube video 100%, right?
Yep.
And then is that going to be shown in class?
No.
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 No. Okay.
No, when I